Hello everyone, I'm Dr. Sanjana Voladoddi, a senior resident in the Department of General Surgery. Today I will be taking the topic for discussion, gastric perforation from pathology and prognosis. The epidemiology suggests globally that the peptic ulcer disease for a lifetime prevalence is around 5 to 10%. Perforation complicates 2 to 4% of the ulcers, second most common after bleeding. Declining incidence in the West is due to H. pylori eradication with the use of PPIs. There is shifting demographics, which shows increasingly the elder population is being affected by this disease. The Indian data suggests that peptic perforation remains the most common cause of perforation peritonitis in India, which also shows a male preponderance of more than 90% of the cases. Younger age at presentation in India is approximately 40 to 46 years of age compared to the Western countries. H. pylori prevalence in Indian peptic perforation is approximately up to 55%. Enteric fever and TB are major cases of non-peptic GI perforation, which is unique to India. In India, duodenal perforations are more common than gastric perforation in the younger population. The etiology and classification are as follows. Peptic ulcer perforation is the most common cause, mostly seen in anterior duodenal area. Drug-induced such as NSAIDs and corticosteroids are also seen. Malignant perforation is a cause where gastric carcinoma can be seen. Iatrogenic causes are when you do your endoscopic procedure or post-stent placement procedures. Traumatic causes are penetrating and stab or gunshot injuries. Other rare causes is your foreign body ingestion, caustic ingestion of alkali or acid, gastric volvulus with ischemia, or a neonatal spontaneous perforation. The pathophysiology we will discuss as a three-phase cascade, where first step for the cascade is chemical peritonitis, which occurs within the 2 hours of presentation. The second stage is the silent phase that occurs from 2 to 12 hours, which shows a transient symptom quiescence, where the patient paradoxically shows improvement in symptoms. And the third phase is the bacterial peritonitis, where most of the patients present to us in the emergency department. That is over 12 hours of onset of symptoms. This is basically your infection and systemic response phase. The clinical features and diagnosis of a peptic ulcer perforation is as follows. There is sudden onset severe epigastric pain or tenderness, which is also called a thunderclap abdomen. There is board-like rigidity, which is the most common classic sign on your clinical examination. There will be absent bowel sounds and the liver dullness will be shifted with the presence of air. On X-ray, we will also see a Valentino sign. The patient will also have a tachycardia and hypotension on presentation. Routine investigations when we suspect a patient of an ulcer perforation are erect chest X-ray to see the free gas under diaphragm, a CT or a CECT abdomen is gold standard investigations, and an erect abdominal X-ray where we see a regular sign or a double wall sign. Other signs that is of importance theoretically is falciform ligament sign and football sign, which is nothing but your massive pneumoperitoneum captured on the X-ray. Other blood investigations done routinely is serum amylase, ABG plus lactate, which is of clinical significance in this case. To discuss whether you have to decide a non-operative or an operative management for a peptic ulcer disease is by a Taylor's method. That is nothing but a non-operative or a conservative management is used in the patient who fall under these named criteria. That is a sealed off perforation on a CECT abdomen, or a patient who is hemodynamically stable, patient has no generalized peritonitis, if the symptom duration is less than 24 hours from the onset, or there is improvement of the symptoms within 12 to 24 hours of the onset. When to operate is almost always in a patient with generalized peritonitis, pneumoperitoneum with clinical signs of perforation as discussed previously. In a patient who is not stable hemodynamically, a failed conservative management, a gastric perforation will definitely require an intra-op mandatory biopsy to rule out any carcinoma, or if you are uncertain about your diagnosis. The components of a conservative management or in a patient until you shift the patient to the OT, these are the components that you have to follow. Keep the patient NPO and decompress with an NG tube. Start IV medications as PPIs and antibiotics as required. IV fluids with close clinical monitoring of all the vitals along with your urine output and abdominal girth. According to the World Society of Emergency Surgery, the guidelines suggest that the conservative management largely abandoned for gastric perforations have high failure rate. Some of the surgical techniques, whether open, laparoscopic or endoscopic, that we can see for management are: in your open repair, a Graham's omental patch is most commonly done. You can also opt for a simple primary closure with an omentopexy, or a definitive surgery, which is rarely indicated now, is a truncal vagotomy with a drainage procedure only if you are suspecting or if it is a proven recurrent ulcers which are not caused by H. pylori or NSAIDs. A laparoscopic repair, which is an increasingly chosen form of surgical management. These are indicated only when the patients are hemodynamically stable or a perforation is less than 1 centimeter, or the patient has come to you within 24 hours, a BMI of less than 30, or with no prior history of an abdominal surgery. There is a large perforation or a friable tissue on laparoscopy, or if there is extensive contamination of the abdomen. We can also look at the emerging steps or emerging repairs endoscopic approach, that is through the scope clips or over the scope clips for perforations which is less than 2 centimeters. You can also perform an endoscopic suturing provided the ulcer is more than 2 centimeters, or a surgical consultation mandatory even after a successful endoscopic repair. So the patient has to definitely be under constant follow-up. The key intraoperative steps that should be followed in any of these methods chosen are thorough peritoneal lavage. Minimum of 3 to 6 liters of warm saline has to be used. Always inspect both the anterior and posterior walls for a perforation. Always take biopsy from the ulcer edge to rule out a malignancy. Methylene blue or an air leak test is used to confirm the integrity. Drain placement is also followed. Post-operative care and complications. Immediate post-operative management, you will have to do an NPO with NGT decompression, approximately to 2 to 4 days, as the bowel will take time for it to come back to the normal function. IV PPI therapies, empirical antibiotics, DVT prophylaxis, incentive spirometry, and early ambulation as suggested in ERA's protocol. A water-soluble contrast study is also suggested post-operatively to confirm the seal. H. pylori eradication is a very important step that can prevent gastric ulcer perforations. Complications as seen in the early and the late duration are as follows. Early complication is suspected in the first 7 days post-operatively. That is a suture line leak, intra-abdominal abscess, wound infection, paralytic ileus, or your respiratory complications such as atelectasis and pneumonia. Late complications are incisional hernia, adhesive intestinal obstruction, recurrent ulcer if you have not taken care of H. pylori eradication, and your gastric outlet obstruction. The key takeaway or conclusion from this class are that gastric perforation is a surgical emergency, so diagnose early, operate early. Every hour of delay increases mortality. An erect chest X-ray is 70 to 80% sensitive, and the CECT is your gold standard. Absence of free air does not exclude perforation. Graham's omental patch remains the workhouse procedure worldwide. Laparoscopic repair is gaining ground right now. Always biopsy the ulcer edge in gastric perforations. H. pylori eradication is the most simple, important step in preventing recurrence. Boyce code is quick and practical for risk stratification. In India, perforation operation interval is the most modifiable prognostic factor. Advocate for early presentation. Thank you.